So in the world of ESRD and vascular access, we have a difficult situation. We only have three options for folks to get dialysis. Those are catheters, grafts, and fistulas, and each of those comes with a problem. Catheters, of course, are high infection rate. Fistulas, many of them don't mature and takes a long time to mature. In the cases where they do, up to 50% in the US. And grafts are they mature wonderfully, they don't get infected like catheters do, but the problem is they need lots and lots of interventions. So what does that mean, lots of interventions? They require, on average, a angioplasty about every 3 to 6 months. And that is an incredible burden on patients. And so I don't look at it as the realm of a surgeon or the realm of an interventionalist. They're all our patients. They all have lives that we're disrupting by doing lots of procedures. And so when I started thinking about this, I recognized early on that the disease state, the frequent interventions that occur in grafts specifically, occur at the venous anastomosis. 90% of them are at the venous anastomosis. And wouldn't it be nice if we had some kind of solution? And I'd been thinking about what that solution could be, and I quickly came to understand that the two main reasons for stenosis to occur at the venous anastomosis are neointimal hyperplasia due to shear stress and due to the infiltration of cells from inflammation. Well, the way that we try to solve those two problems, the shear stress as well as the inflammation, is by creating a new procedure with a new device, but mostly a new procedure that allows us to make an endovascular anastomosis as opposed to a traditional surgical anastomosis. And one of the ways that we solve the problem is because we decrease shear stress. A typical anastomosis that's surgically created is an end-to-side anastomosis with lots of turbulent flow. When we do a endovascular anastomosis, the flow tends to be very laminar because it's not an end-to-side, but an end-to-end delivery of blood into the vessel. And the second way that we help that is, instead of having to isolate the vein, having to remove it from its in situ tissue bed, clamping it, and then sewing PTFE onto it, we leave it in its native bed. We simply cannulate it with a very small needle. There's no sewing of any kind, and that reduces inflammation tremendously. And both of those factors are what we think helped us achieve our outcomes in our clinical trial. Well, we have a very successful clinical trial. We've been working on the EndoForce for 10 years now. We were, of course, victims of COVID in the completion of our clinical trial. It was very difficult to recruit patients during that time, but we completed the clinical trial, and what we discovered was that our cumulative patency for grafts at 6 months is 92%. And that compares very favorably to a traditional sutured anastomosis, where the 6-month patency, cumulative patency, is 80%.